So today we will discuss the management of stable angina. It is an LO in the initial pages of document of cardiorespiratory module. We have previously discussed other aspects. However, we will recap through pathophysiology, clinical features, investigation, risk stratification, management, revascularization, and to some extent clinical MCQs. So when there is a critical imbalance between oxygen supply and demand and coronary perfusion pressure and blood oxygen carrying capacity is hampered, heart rate, blood pressure and wall tension also determine demand. There may be some ischemia or angina due to a fixed atherosclerotic narrowing. What are the clinical features? Obviously, all of you know already that there is central chest pain, exertional discomfort that is relieved by rest, aortic stenosis, hypertension, and arterial diseases are scanned for while examining these patients, and also a screening for anemia, check for thyrotoxicosis features, and blood pressure is done. They also increase angina. How would you distinguish between a myocardial ischemia and common normal variant found during exercise stress testing to ensure accurate diagnosis and patient evaluation? So when there is a planar ST depression, is a hallmark of myocardial ischemia when drop is planar and more than 1 mm. Downsloping is strongly correlated with severe underlying coronary artery disease during stress testing. Upsloping is a normal finding and generally lacks specificity for active ischemia. However, digoxin, LV hypertrophy, bundle branch block, or WBW may be cause of a false positive ECG changes on exercise tolerance test. Why exercise tolerance test in a high probability setting? Exercise tolerance test is the best way, especially in male patients, to screen for coronary artery disease in the form of stable angina. And as you know, that history of angina, stable angina, is that it increases on exertion and relieves with rest. And this exercise tolerance test specifically fits that very well. How would you risk stratify a stable angina patient? When there is post-infarction angina or ischemia at workload on exercise tolerance test, patient has poor effort tolerance, there is a great possibility of left main coronary artery or three vessel coronary artery disease obstruction, and if the ventricular ejection fraction is less than 35%, it is also one of the high risk factors for a stable angina patient. Low risk factors are predictable exertional angina, good effort tolerance, one or two vessel disease with good LV function. Pharmacological management. Whenever we are managing a person, a patient, First of all, we have to go for precision medicine. But given that the aspects are symptomatic, then prognostic, to some extent preventive, so there are different drug therapies. One is for improving long term survival and outcomes and effective relief of symptomatic conditions. The other for that. So aspirin and statin, 75 mg aspirin. Statins are essential for block stabilization to improve overall prognosis. Nitrates will induce venous and arteriolar dilatation for relief of symptoms. 6 to 8 hour nitrate free interval daily needed to avoid development of nitrate tolerance. Beta blockers are the first line treatment option. They reduce heart rate and blood pressure, but do not withdraw beta blockers abruptly. It is said about beta blockers that start low, mean the lowest dose possible, and go slow. You gradually increase the dose to maximum, but you don't stop them abruptly. Calcium channel blockers, including dihydropyridines like amlodipine, or rate limiting non dihydropyridines, verapamil or diltiazem, will help manage symptoms effectively by blocking calcium channel. There is another way to go invasively. If your medical therapy fails, you go for PCI angioplasty and stenting. Angioplasty and stenting is a short stay procedure of 12 to 36 hours, and in 2 to 5 days, patient may return to work. Light work, obviously. Survival benefit is none in stable ischemic heart disease, means the patient doesn't have any mortality benefit. The major issue is the restenosis, and graft patency is not applicable for PCI or angioplasty. In simple terms, angioplasty is going to the artery, opening its obstruction with a balloon, and then putting a stent or you can say a steel mesh and that will prevent recollapse immediately and in the long term if the things go well. Cabbage surgery, on the other hand, has a longer stay for 5 to 8 days with return to work in 6 to 12 weeks, and it is especially beneficial in three vessel or left main disease, and it has a survival or mortality benefit. But major risk is that patient may have stroke, infection, and other complications of surgery, and the graft is patent more than 80% in internal memory artery at 10 years. Given the patient risk factors controlled, for example, if he was previously diabetic, hypertensive, and hypercholesterolemic, you need to treat that even after bypass. Otherwise, the graft will close early. So, whenever we are diagnosing these patients, arresting 12 DTCG is first, but not is sufficient on its own alone. So, you may go for exercise tolerance test And if that doesn't work out, you may go for CT angiography or invasive coronary angiography. Clinical history, here the order is on the three, but actually clinical history is much more important and gold standard in any clinical setting, including stable angina. And if you are not satisfied with the superficial vision of coronaries through coronary angiography or CT angiography, there may be assessment for the muscle functional imaging, which will show blood flow during stress and rest. But this will often be done before intervening with a stent or with a bypass surgery. Myocardial perfusion is then required. So, what are the factors that affect myocardial oxygen supply and demand? Obviously, heart rate, high blood pressure, contractility, LV hypertrophy, valve diseases like aortic stenosis, aortic regurgitation increase oxygen demand and they will exacerbate angina. Duration of diastole, coronary perfusion pressure, aortic diastolic minus coronary sinus or right atrial diastolic pressure, coronary vasomotor tone, hemoglobin and oxygen saturation will affect oxygen supply, that is coronary blood flow. Duration of diastole is shortened by tachycardia because two-thirds of the cardiac cycle is diastole and it is shortened during tachycardia. So these are the different views how ST depression is viewed. A planar ST depression in A, downsloping, these both are not good. An upsloping depression may be a normal finding as shown in the C. This is a positive stress ECG, chest leads only. Minor T wave changes in inferolateral leads, but after 3 minutes exercise on treadmill, you can see V4 and V5 showing planar ST depression. You can see, and it is quite significant. Later on, this patient underwent angiography because he was a high risk patient, so he had 3 vessel coronary artery obstruction. So high risk post infarct, poor effort, ischemia at low workload on ETT, left main of triple vessel disease with poor LV function, and low risk is predictable exertional angina, good effort balance, ischemia only at high workload, single or two vessel disease, and good LV function. However, patient doesn't strictly follow these strict criteria and may fall in between. This is a myocardial perfusion scan showing reversible anterior myocardial ischemia, cross-sectional image of the LV. The resting scans on the left show even uptake of the tracer technetium 99 labeled tetrophosphine, and these look like so beautiful donuts. But during stress, when dobutamine infusion was given, you can see there is a reduced uptake of technetium, and you can see along the anterior wall there is reduced intake of technetium. And these look like crescents. What do you tell a person who is having stable angina? You tell him stop smoking, maintain weight, regular exercise but within limitation of discomfort. Don't push yourself beyond limits. Avoid severe unaccustomed exertion and vigorous exercise after a heavy meal or in a very cold weather. And take sublingual nitrate before undertaking exertion that may induce angina. So, whenever there is stable angina and you have found it, give the stress test. If it is negative, you are doubtful, CTA angiogram and review diagnosis. Stress test is positive lifestyle advice, secondary prevention with anti-anginals, and if he is a high risk person, as we discussed previously, invasive angiography may be the best option. And if it is not high risk and there are, then you look for symptoms despite treatment. And if the treatment is successful and there are no symptoms, the medical therapy continues. But if there are symptoms, you go for invasive angiography. And if suitable for revascularization, you will tell the patient for angioplasty and stenting and or bypass surgery. And if not, then you tell the patient to continue medical therapy. This is the wrong turn in so much medical practice in our country. People are so much concerned about benefits of angiography. Suitability for revascularization is then assessed on the table. Sometimes the patient is told that you are not suitable for any intervention. Then the patient thinks that it is the end of the story or end of life for him. However, it is not like that. Medical therapy has still value under the supervision of a qualified cardiologist. Obviously, this is not some general practice stuff to be followed on its own. As far as symptomatic treatment is concerned, sublingual glycerol trinitrate 4 to 8 minutes starts peak action and persists for 10 to 30 minutes. Buccal GTN 4 to 10 persists long duration. Transdermal 1 to 3 hours peak action and may persist up to 24 hours. Oral isosorbide dinitrate 45 to 120 minutes, 2 to 6 hours. And oral isosorbide mononitrate. Peak action is 45 to 120 minutes and duration of action is 6 to 10 hours. So the most rapid is sublingual glycerol trinitrate for peak action. We said that previously as well, nifedipine, cardipine, amlodipine, verapamil, they can be used, for example, nifedipine 5 to 20 mg 3 times a day, but it can cause marked tachycardia, so it is not really favored by cardiologists. Nicardipine is another medication, 20 to 40 milligram 3 times a day. It causes less myocardial depression than other calcium antagonists. So, with low ejection fraction and a possibility of heart failure, they may be better with nicardipine. Amlodipine, 2.5 to 10 mg daily, ultra long acting drug, very good medication for management. Verapamil 40 to 80 mg 3 times a day. It commonly causes constipation and also has antiarrhythmic properties. Delta has M60 to 120 mg 3 times a day. It has similar antiarrhythmic properties to verapamil. Slow release preparations are now available for both verapamil and deltazid. The balloon angioplasty, I wanted to give you a concept. This is PCI is more effective than medical therapy in alleviating symptomatically and improving exercise tolerance, but it will not reduce mortality. It carries risks of procedure-related MI, emergency CABG, and repeat procedures for stenosis. In comparison with simple balloon angioplasty, which is this second diagram, 1 and 2, is a simple balloon angioplasty. The stenting in the third stenting, it will reduce restenosis 17 versus 40% in the upper one, and recurrent angina 13 versus 30%. Restenosis rates are reduced even further, less than 10% when drug-eluting stent is used. As shown in this diagram, there is a stent in place. Until step 2, there is angioplasty. Coronary artery bypass grafting. You can see left internal memory artery being grafted to left anterior descending artery, and saphenous venous graft is done to right coronary artery. There is also a saphenous venous graft to LAD. CABG is superior to medical treatment for at least 10 years after the surgery in terms of survival. Greatest benefit in those with significant stenosis in the left main coronary artery. Left main coronary artery is somewhere here, it is hidden here, but it is. And when it is grafted, obviously, are those having all vessels, three vessels disease, and especially if they have impaired left ventricular function, they will benefit more from bypass surgery. So in comparison, death in PCI is less than 0.5% versus CABG less than 1.5 during the procedure. Myocardial infarction 2% versus 10%. Hospital stay is shorter in PCI and longer in bypass up to 8 days. Patient return to work in 2 to 5 days in PCI cases and 12 weeks in CABG. Recurrent angina 15 to 20% at 6 months in PCI, while 10% at 1 year in CABG. Repeat revascularization 20% at 2 years in stenting and PCI versus 2% at 2 years. Neurological complications during angioplasty and stenting are rare, but they are common in bypass surgery. So that is why before surgery, carotid Doppler ultrasound of the patient is done. Other complications are emergency. In the angioplasty may turn into emergency CABG. You may have a complication in the procedure, and you may need surgeon to intervene. Vascular damage will related to access site, for example, if it is done from the femoral artery and the abdominal aorta may be damaged. From the radial spasm, radial injuries can occur. While in CABG, diffuse myocardial damage, infection, wound pain, etc. are the complications during CABG. Now we come to the major statement of systematic reviews and meta-analysis. Similar rates of death and MI and similar quality of life. PCI is associated with a greater need for repeat procedures, although this has been halved by the introduction of intracoronary stent implantation and newer stents For patients with multivessel disease or diabetes, coronary artery bypass graft appears to confer better survival at 4 to 5 years. Sometimes people have normal coronaries and they still have angina. Who are they? 10% stable angina and predominantly female patients. There are multiple distinct pathophysiological entities, and obviously, normal angiography or normal arteries along with anginal symptoms is really a diagnostic challenge. However, good news is that the prognosis is generally not very worse. Vasospastic angina, 30% prevalence with epicardial coronary spasm and has a moderate female predominance. Syndrome X, 60% with microvascular dysfunction and a high female predominance. Other causes 20% multiple etiologies and variable between genders. Vasospastic and prismatic angina. Coronary artery spasm during exertion or at rest, especially in the early morning hours with ECG changes, and the abnormal vasomotor activity of coronary smooth muscle, potentially mediated by endothelial dysfunction, enhanced sympathetic activity, and altered ion channel regulation. Angiographic findings will demonstrate normal coronaries at baseline, but during a provocation test with certain medications or spontaneously during symptom episode, there may be narrowing. So you do have Holter monitoring or continuous cardiac telemetry to document ST changes during spontaneous episodes. Acetylcholine or argonovine challenge during coronary angiography to reproduce spasm and confirm the diagnosis. Symptom correlation between temporal relation between chest pain and ECG changes strengthen the diagnostic confidence. Calcium channel blockers to smooth muscle relaxation with high efficacy as a first line medication is a good medication. Long acting nitrates through vasodilatation with high efficacy and first line status. Beta blockers sympathetic reduction, however, they have moderate efficacy and used as adjunctive treatment. Statins restore endothelium. They are supportive and they are also used as adjunct therapy. Syndrome X and microvascular angina are distinct entity with a triad of typical exertional angina, objective evidence of myocardial ischemia on stress testing, and normal coronaries on angiography. Middle-aged women with multiple cardiovascular risk factors. Pathophysiology is microvascular dysfunction with impaired endothelial dependent vasodilation and abnormal coronary flow reserve. Diagnosis require careful documentation of symptom characteristics, positive stress test findings, and exclusion of coronary obstruction through angiography or advanced imaging techniques. So significantly lower mortality and major adverse cardiac events rates compared to obstructive coronary artery disease with 95% 5-year survival. Nitrates, calcium channel blockers, and beta blockers provide symptomatic relief. And obviously, you will manage risk factors, hypertension, dyslipidemia, diabetes, and smoking. They are crucial. And this syndrome X may change into something else if these are not controlled. This will not remain as syndrome X. One day it will change into the obvious coronary obstruction if the management of hypertension, dyslipidemia, diabetes, smoking, and other is not done aggressively. Thank you very much. This was the stable angina management as per the LO of cardiorespiratory module, Khyber Medical University, Peshawar.